In this presentation, we're going to talk about head and neck injuries. So my objectives are to talk about basic head anatomy. We've already talked about the spine or the neck anatomy in another presentation. Learn how to recognize signs and symptoms of head and neck injuries and how to provide care for those injuries. So we'll start with our head anatomy. The brain is enclosed and protected by the cranium or the skull. And the bones of the skull or cranium are the frontal bone, ethmoid bone, sphenoid bone, two parietal bones, two temporal bones, and the occipital bones, as you can see in our picture. The scalp covers the skull and it's composed of 5 different layers of soft tissue. We'll talk about some of these tissues in a later injury. And the purpose is to protect the skull. It's like a padding for the head. And it also provides protection for the brain too. Speaking of the brain is composed of several different areas. The main brain is called the cerebrum or the gray matter or the cortex. This is what you think about when you think of your brain. It's the area that controls the most conscious and sensory functions, controls emotions and our personality. Next area is the cerebellum, also known as the little brain. It's responsible for equilibrium and muscle coordination. Pons controls our sleep, posture, respiration, and the other things on the screen. And our last area is the medulla oblongata, also known as the brain stem. This is all the automatic things that we do without thinking about it. So some prevention things to talk about for head and neck injuries. First one is wearing protective headgear and using headgear properly. I'm going to talk about these a little bit. Now, it's our responsibility, if you're a coach, athletic trainer, parent, to make sure that the athletes are wearing headgear that fits them correctly. Number one thing that drives me nuts is when I watch a football game on TV and the helmet moves easily around the athlete's head. The helmet should be stuck on the head pretty tight. It should be very difficult to get a helmet off the head. It needs to fit correctly. It's our responsibility to make sure that the athletes are wearing the correct type of helmet, correct size of helmet. And this goes with baseball too and softball, any sport that wears helmets. And the other thing is make sure that we're not using like an adult size helmet on a youth, or let's not give our old equipment to younger people. That's not the right thing to do. There's a reason why we don't hand down helmets and other gear, because it's probably, if it's no good for one team, it's not going to be any good for another team. So it's our responsibility to make sure headgear is sorry about that, I dropped my microphone, is the correct size for the athletes. Okay. Next point. Teaching athletes to use proper techniques when tackling or making contact. This is not just in football. This is all sports. But in football, we see what you're going to hit with your eyes up. The reason why that's critically important is when you drop your head, and if you're not looking at what you're hitting, if you hit a person on the top of your head, all that force is going to go to the neck, and that's how a lot of neck fractures happen, is hitting somebody with the crown of your head, or if you're diving onto the swimming pool. A lot of neck fractures in the swimming pool happen because somebody dove and hit the water, which is like hitting cement, on the top of your head, and that force goes straight down into your cervical spine, and then you have a neck fracture. So you need to see what you're going to hit. It's our responsibility to teach athletes proper and safe hitting techniques. There's a lot of stuff on the internet that teaches proper tackling techniques for football and all the other sports. Mouth guards are another way to help with reducing the severity of concussions. This is probably not as in vogue as it was a while ago. Don't know if it helps as much as we thought it did, but it sure can't help but help the teeth. Spotters means when you have people coming off a field or a court, you look at them to make sure that they aren't suffering a concussion, especially if you saw somebody taking a really big hit. You want to check them out. Now in the NFL now they have people who are looking at athletes and they'll see that somebody's kind of unbalanced and they'll beep down to the ground and tell the on-site athletic trainers and doctors to go check on that person. I think that's something we need to do at all levels of athletics for all sports. For the neck, we should start working on neck strengthening exercises. Again, go on internet, YouTube, you can find all sorts of good exercises for this. In football, we use things called neck rolls, where they connect to the I just blanked on what they're called. The shoulder pads, and it keeps somebody from their neck whip lashing back. And this is used for people who have previous injuries. Now we're going to switch gears to head injuries, also known as closed head injuries, or CHI. These are injuries to the brain or the skull. Basic 4 types. Concussion. This is the general definition of a concussion is a temporary malfunction of the brain. We're going to go over most of these injuries in more detail. Contusion, bleeding, and possible swelling of the brain tissues. Bleeding or hemorrhage and hematoma. Hemorrhage means bleeding. Hematoma is when the bleeding gets hard. That's bleeding or pooling of blood between tissue layers covering the brain or within the brain, and we're going to talk about that one more. And skull fractures or fractures that crack or break in the skull. All these injuries typically take place by 2 different kinds of mechanism of injuries, coup and contra-coup. So coup mechanism of injuries happen when the head is stationary and is struck by moving objects. So like in a picture, the person is stationary and gets hit by a baseball. The brain is traumatized at the location of the impact. Whereas contra-coup is the head is moving and makes contact with an immovable object such as a floor, a wall, anything that's not moving. The result is a deceleration injury. The brain impacts the opposite side from the side of contact. So the brain kind of bounces. So you hit your head on the picture there. The person is falling back, hits their head on the floor or wall, whatever it is. The head goes, the back of the skull hits the back of, or the back of the brain hits the back of the skull, then bumps forward and can hit the front of the skull too. These are the worst kinds of MOIs for head injuries. So if we have an unconscious athlete with a closed head injury or a neck injury, we assume we're going to classify this as a concussion. But typically when somebody's unconscious, we just treat everything like a head or neck injury, a serious head or neck injury, fractured neck, those type of things. Our signs and symptoms here, the person doesn't respond. We say, are you okay, or are you okay? No response to stimuli. So that means they're unconscious. They could have irregular breathing and an irregular pulse. They can have bleeding at the head, nose, ears, or mouth. Deformity at the site of injury. Convulsions. Pupils may not react to light or may be unequal in size. So as a reminder, pearl, the word pearl stands for what is normal for our eyes. Pearl stands for pupils equal and react to light. So the pupils are the same size, and when we use a pin light or they open and close their eyes, their pupils will constrict and dilate to the light on both eyes. That's what's normal. They don't have pearl in this situation. So if we have this situation, this is an immediate call EMS, call 911, activate your emergency action plan, stabilize the head and neck, which we talked about earlier in the class, maintain the ABCs, control any bleeding, do not use smelling salts, and most people don't use those things anymore, but still got to say it, and do not remove the helmet, because the helmet is protecting the head at this point. So just leave that helmet on. We can take off the face mask if we need to. Okay, so that's for an unconscious person who's we treat as a head or neck injury, and it's life-threatening here. Now we're going to talk about the conscious athlete with a concussion. So we used to talk about a bunch of grades of concussions. I think that's not really used all that much anymore. We'll just say it could be mild to severe. Mild is bell rung, not concussed. They could be still have a concussion and not have any unconsciousness, but we'll just call it mild signs and symptoms. We'll talk about signs and symptoms here. Severe is anybody who's lost consciousness. Okay, so here's a lot of signs and symptoms. So the signs and symptoms: no loss of consciousness, 2 loss of consciousness up to minutes. Okay, you can still have concussion and not lose consciousness. The person can have a headache, dizziness, confusion, and nausea. Nausea, again, is a feeling like they're going to throw up. They can have a loss of memory. They can lose memory from before the injury happened, or they can lose memory from the time since the injury happened. And we'll talk about that in our concussion evaluation lab. They can have ringing in the ears. They can be sensitive to light. They can talk different. They can have different motor responses. That means muscle responses. They can be confused. They can be disorientated. They can have slurred speech. They can have emotional change. Okay, so we have any of that. What do we do for this person? Okay, so I provided a document in class. This is the consensus statement on concussion in sport through the British Journal of Sports Medicine, which it talks about how do we manage somebody who's got a concussion. So the first step, I'm going to go through these steps. The first step is medical assessment. We'll talk in our lab class how we do the assessment. This needs to be done by a trained medical professional. It doesn't have to be an MD, but it should be an certified athletic trainer or somebody who is trained in this area. We'll talk about some standardized way that we do these medical assessments. After that, we have complete rest for 24 to 48 hours from physical and cognitive rest until we need to keep them resting until the symptoms go away. If they have any symptoms, they need to completely rest. At your school, you should have a concussion return to play policy and procedures manual that is agreed upon with all the coaches, the athletic training staff, the athletic department, the school nurse, and the principal on when an athlete sustains an injury, what they can and cannot do as far as classes go. Because some of these athletes may not be able to go to class because they're having such problems with their concussions, they can't go to class. So that needs to be part of your concussion policy and procedures manual. Okay, the third step is symptoms limited activity. That means 10 minutes of slow walking, no resistance training, no contact activity allowed. This means that this person, once they get to step 3, they have no signs and symptoms for 24 to 48 hours. Then they go to step 3. When they do step 3, they do those activities. They have to be symptom free for 24 to 48 hours after they do number 3. Number 4, then they, after they're symptom free for 24 to 48 hours, they can go to step 4, the light exercise. After they do that exercise and they're symptom free for 24 hours, they go to step 5, then they go to step 6, step 7, 8, and 9. Okay, so I'm not going to read each step there, but you can see that. The point is it's gradual. They have to do that next step during the activity, like in step number 6, non-contact training. They're doing those exercises. They don't have any signs and symptoms. They rest for 24 hours. They come back 24 hours later. They're still symptom free. Then they can go to step 7, be re-evaluated, make sure that they're at pre-concussion measurements, and then they can go back to full contact and return to play. Okay, it is a gradual. Each person's different. It's not going to be the same as an ankle sprain or an ACL. So, because we're talking about people's brains. I just want to touch on the standard assessment of concussion, or SAC test. SAC is used to determine the severity of concussion. We're going to talk about this one more in our lab. We typically will use some kind of measurement at beginning of the season to develop a baseline measure, so we can compare that score once a person sustains a concussion, and then we can get them back to normal rates by the time they return to play. Do 5 main areas: orientation, immediate memory, concentration, delayed recall, neurological screening. Again, we'll talk about these in the lab. Just so you know, here in California requires anybody who's coaching to get training on concussions. I provided a link in the class for the NFHS training. It's free. You can take it. You can get the certification. So very important for you to do that if you're a coach. Our next area is subdural hematoma. So this is bleeding in the brain. This is a medical emergency. This is the cause for most athletic-related head trauma. So initially, after the injury, the individual seems normal, may not have any signs and symptoms. Slowly, as the blood starts accumulating in the brain, they start developing a headache, decreased consciousness. You can have a change of cognitive, that's their mental, behavioral, muscle ability. You can have dilation of pupil on the injured side. They can be nauseous, get sleepy, and it may take up to 48 hours for these signs and symptoms to be displayed. So this takes time. So what we do with this is a life-threatening condition. So typically what we do, wrong person, wrong place yet. Athlete must have a CT scan or MRI to rule out subdural hematoma. So typically when somebody has concussion, they don't really have too many signs and symptoms. Maybe they have a headache or something like that. Nothing life-threatening. We'll typically have somebody assigned to wake that person up every hour or so, maybe 2 hours, to check if their signs and symptoms have changed. Okay, wake them up. Hey, how you feeling? If they got a headache, that when they didn't have a headache before, they start talking differently. If that happens, that's immediate call 911, because that means there is bleeding in the brain. They have to have that CT scan or MRI. Now the next type is an epidural hematoma. This is bleeding between the skull and the brain. Typically happen with coup or contra coup. This happens, the athlete is unconscious at the time of the injury and will remain unconscious, or will regain the consciousness for a brief period of time before collapsing. So the signs and symptoms here are mild, then become severe really quick. So the difference between subdural is slow, epidural is really fast. The level of consciousness will vary from fully awake to drowsy to comatose. This person is going to have increased blood pressure, decreased pulse rate, severe head pain, dizziness, nausea, dilation of pupil on the injured side, and sleepiness. They may have muscle weakness or paralysis. Treatment here is recognize those signs and symptoms and get them to the emergency room as soon as possible. Paramedics get them on the ambulance. They're going to cart them up and get them there because this is life-threatening. PostConcussion Syndrome, we're really not sure why it happens. It can happen after a mild head injury. The signs and symptoms include headaches with exertion, dizziness, tinnitus is ringing in the ears, fatigue, irritability, frustrations, etc. These can last weeks, or days, weeks, or even months after the head injury. I think there was a hockey player that I think he was out for almost 2 years because of this. So the point is, don't let that athlete return to activity until all the signs and symptoms have resolved. We talk about the return to play. Second impact syndrome is when an athlete gets a second head injury before the symptoms of the first head injury have not resolved. Usually an athlete will become unconscious, will not become unconscious, but will appear dazed and then will collapse into a coma. This is life-threatening. This is call 911 immediately. They need to be taken care of. Again, this is why we follow those graduated return-to-play protocols. Skull fracture. So we get hit from a bat to the head. Signs and symptoms here. So we have raccoon's eyes. So we have discoloration around the eyes. We have Battle's sign, discoloration behind the ears. We can have discoloration or depression in the skull from the bat. We can have Rhinorrhea, which is cerebral spinal fluid drainage from the nose. This is a halo or ring sign, so you get something white, dab their nose, and we'll see blood on the white container, white pad. Otorrhea, which is the cerebral spinal fluid drainage from the ear, as you can see in that picture. Treatment here is 911. Treat for shock, control that bleeding. Don't stop the cerebral spinal fluid coming out of the nose or ear. I mean, if it's dripping, you can have them stop, but you don't want to really stop it because that's helping the pressure come out of the brain. So our last thing is conscious neck injury. It could affect the low back, neck, arms, feet, toes, and fingers because of the spine. Direct blow or compression or twisting for this. Can have loss or abnormal sensation or tingling. That's the main sign of any nerve injury. They may lose that muscle strength, or they can't move the body part. Their muscles can spasm. So our management here is if we have any of those, loss of sensation, ability to move, body part, call 911, stabilize head or neck. If they have abnormal sensation, tingling, and otherwise pain-free, hopefully you have a doctor on site that can help them take care of that. Just a review, head anatomy. We talked about the different bones and the different areas in our head. We talked about closed head injuries. We talked about unconscious and conscious closed head injuries and neck injuries. We talked about concussions, and the key thing is when in doubt, hold them out. It's better to be safe than sorry.